Good evening, and thank you for joining us for our webinar, Pelvic Health Therapy for Prostate Cancer Recovery. This evening, our speakers are Kristin Kirk-Hostetler, physical therapist and certified doctor of physical therapy. Kristin earned her doctorate in physical therapy from East Tennessee State University and joined Tennessee Urology in 2017. She specializes in treating chronic pelvic pain, pelvic health for prostate cancer recovery, and incontinence. She sees patients in our Oak Ridge and Powell offices. Our second speaker is Synowiez, who is a licensed and registered occupational therapist. She earned her master's degree in occupational therapy from Tennessee State University in Nashville and specializes in pelvic health therapy. She received her pelvic health education and training from Herman and Wallace Pelvic Rehabilitation Institute. Autumn joined Tennessee Urology in 2018, and she sees patients in our Oak Ridge and Powell offices. Welcome, Kristin and Autumn.
Hello. I guess we'll get started. My name's Autumn. And there's Kristin, just in case you can't tell from the pictures. I just wanted to start by kind of going over what we will be covering. So the topics that are going to be covered tonight are prostate cancer and PSA, prostate, what is the prostate, how it affects our bladder, prostatectomy, male anatomy, urinary incontinence, pre-op therapy, and post-op therapy. It is September, that is Prostate Cancer Awareness Month. I wanted to talk a little bit about prostate cancer facts and some screening tools that are used to make sure that your PSA and prostate don't have any signs of prostate cancer. And if they do, it's very important that you do these screening tools every year with your primary care physician or your urologist. So some current prostate cancer facts is that all men are at risk for prostate cancer, and it is the second leading cause of cancer death in men behind lung cancer. 1 in 9 men will develop prostate cancer. 6 in 10 of those men that are diagnosed are over the age of 65, with the average age being 66. And typically it's rare that someone under the age of 40 would be diagnosed with prostate cancer. Another risk factor can be age. As men get older, they are at more risk for being diagnosed with prostate cancer. And African American men are more likely to have prostate cancer as well. And when they're diagnosed, they're typically younger and their prostate cancer is more aggressive or more advanced. And family history is another risk factor that we can look at in your medical history. If your uncle, brother, father, grandfather has had prostate cancer, there's a higher risk of you being diagnosed with prostate cancer at some point in your life. So when it comes to screening tests, before you even have prostate cancer, it's good to have your physicals every year. And during your physical every year, your doctor should be doing a blood sample for your PSA and a digital rectal exam. And it's important that both of those tests are done together, because it could be possible that your PSA is under the normal value, but there could be a digital rectal exam that would exhibit a nodule or a tumor or a change from the previous year. So the PSA is the prostate specific antigen. It's a protein made in the prostate, and typically that is done through blood work by your physician. Usually the number that they're looking for is 4 or below, but that does vary based on your age and other health conditions. A digital rectal exam is an examination done by your physician where they use a gloved finger to insert through the rectum, and what they're looking for is, are there any nodules, tumors, or changes in your prostate that could make them think that there's a possibility that you do have prostate cancer. And from that point, there's other screening tests like a biopsy, MRI, and other screening tests that they can do to further look into that. But if you're someone who hasn't been diagnosed with prostate cancer, or you have loved ones that maybe your son, brother has not been checked by the PSA or a digital rectal exam, make sure that if you have prostate cancer, they're more likely to have that and they need to be checked every year. So now we'll move on to the prostate. What is the prostate? Here's a nice picture below. Right here's the bladder. Here's the prostate. There's the urethra that leads all the way into the urethral opening there. So that kind of gives you an idea of the anatomy here. The prostate is a walnut-sized gland that sits in the male pelvis below the bladder. So you can see that in red right below the bladder. Its job is to provide fluid to lubricate and nourish sperm. So how does the prostate and bladder have anything to do with each other? If you see in this picture here, again, you've got bladder, you've got the prostate right below that. You've got the urethra that runs out of the bladder through the prostate all the way down to the end of the penis where the urethra opens. The urethra exits down out of the bladder through the prostate. And right in here, you have what we like to call, and I learned this from Kristin, your initial brake pads to your urine, to your bladder. What is really called is your internal urethral sphincter. This is actually something that is removed during the surgery. This helps stop the flow of urine and allow the flow of urine, but it also closes during ejaculation to prevent any retrograde of sperm into the bladder. What is remaining once that is removed is your external urethral sphincter and your pelvic floor muscles, which is why it's really important to see a pelvic floor therapist to help yourself maybe clear up any urinary incontinence or anything like that. Since the prostate's job is to help lubricate and help evacuate semen, you will have dry ejaculation once the prostate is removed, but that doesn't mean that you won't be able to maybe potentially have an erection after the surgery or have an orgasm. So there still is a chance for that as well, but I just wanted to kind of make that clear.
The next thing we're going to talk about is the prostatectomy, which is the removal of the prostate due to prostate cancer or a very large prostate, which means you don't have to have a prostatectomy because you have prostate cancer. You can have a very large prostate that's getting in the way of your urinary flow, and you can still have some of the same side effects as if you were being treated for prostate cancer. So when it comes to prostatectomy, it's a surgical operation to remove the prostate gland and seminal vesicles. And sometimes during that surgery, they will remove a lymph node on each side to be tested by a pathologist to see if there's cancer outside of your prostate. Sometimes they may already know that there's cancer in the lymph nodes and remove as many of those lymph nodes as they need to make sure they've gotten all the cancer that they can. Years ago, if you were someone who had this surgery years ago, you may have an incision that starts at your navel and goes all the way down to your pubic bone. And now they're doing that surgery with the robot or the Da Vinci robot, and you'll see each of these dots represents an incision in the abdomen where they insert the robot. And the difference between these two surgeries is that when you had the open surgical incision, your risk factors for infection, recovery time increases, and the severity of side effects like urinary incontinence and sexual dysfunction were more common. But now, if you have the robotic assisted surgical incision, a lot of those risk factors go down, and your possibility of having less incontinence and improved sexual function or regaining sexual function is a lot higher. It is possible to still have the open incision, but usually that's only in a situation where the surgery becomes more complicated, or they already know that they need to do that surgery due to other health issues, complications, or the size of the prostate.
Okay, male anatomy. I love this picture because it shows really clearly where the bladder is, the internal urethral sphincter, and then there's the prostate. You can see the external urethral sphincter, pelvic floor muscles right below that. So after the surgery, they will reattach the urethra back up to bladder, as you can see right here. And so I just thought this really kind of illustrated how important the pelvic floor is for post-op recovery. So if you were to look at the bottom, so at the bottom view of you, so the bottom of a pelvic floor model, you would see all these muscles here. So there's 3 layers of muscles. They all layer on top of each other. I always say it's kind of like a foundation to a house or layers of a cake. They all layer on top of each other. They aid in a mixture of urinary, sexual, and bowel function. These muscles can be over or underactive. So what does that mean? Overactive muscles can mean that they're contracting multiple times throughout the day, whether the person can control that or not, or they're always in a state of tension. So I always like to use the bicep analogy. This is a relaxed bicep muscle. This is a contracted one. So some people come into the clinic and their pelvic floor muscles are already like this. So would I send you home with exercises just to tighten more? No, you'd actually come back to us a week later very upset with your results because they would get worse. So we have to normalize the muscle tone, get it to relax, work out any pain or tension, and then we can start a strengthening program if that's appropriate for you. Underactive just means they're really weak. We need to liven them up. We need to do some exercises, which normally is a Kegel, if that's appropriate for you, also known as a pelvic floor muscle home program. Next bullet point kind of touched on what I already said is Kegels may not be the right exercise for each patient. So we hear a lot people getting pushed Kegels, and sometimes that is not the answer. And in fact, like I said, it can make your symptoms worse. Another reason it's very important to come in to a pelvic floor therapist to get evaluated is the latest statistics is about 70 to 80% of patients are doing them incorrectly. And we see this all day. It really helps with your progress if you get a proper evaluation and proper training. Your muscles can consist of slow twitch, aka endurance muscle fibers, and they can also consist of fast twitch or power muscle fibers. So when I'm talking to my patients about their home program, they're going to do a mixture of long holds and quick contractions. So that can be anywhere from 2, 3, 5, 10 seconds, or, it may be we're just sending them home trying to get a hold of how to do a Kegel. So it really varies with each patient. The slow twitch muscle fibers is about 70% of our pelvic floor muscle, and those are really important. Those are endurance muscles that keep us dry. I always say if you're laying down at night sleeping, if you're just sitting watching TV, if you're just standing in line at the grocery store, these are our muscles that we need to keep us dry most of the day. We need our fast twitch, power, strong muscle fibers to pop in, which is about 30% of our muscle fibers, for times that we're going to cough, or we're going to sneeze, laugh, we're going to lift something heavy. I had a patient the other day say he leaks when he golfs. So we're working the endurance ones along with the fast twitch muscle fibers, those power fibers, to kind of kick in when we need that 100% of muscle power to help reduce any leakage.
So now we're going to talk about what many of you may have tuned in for this webinar for, is about urinary incontinence, and eventually we will talk about how we work on helping you with that. So there's many types of urinary incontinence. We have 4 of those listed here because they are the most common that we see when it's related to prostate cancer treatment. Stress incontinence can occur, like Autumn was saying earlier, if you cough, sneeze, golfing, and we want to work on those fast twitch muscles to help with that. So that's a very common type of incontinence that people come in with, especially after they've had their prostate removed and sometimes after radiation treatment. Urge incontinence is when you leak with a strong urge, when you need to go to the bathroom, or you've heard those commercials where they say, you gotta go right now. That's urge incontinence. And with some bladder training and other exercises, we can improve that. And we commonly see this after treatments like the prostate removal, radiation, and sometimes even with brachytherapy, because that radiation is affecting the prostate tissues over time. Overflow incontinence is when the bladder is filling up and you're not getting signals to the brain as to whether your bladder's full or not, and you're starting to leak because you don't know that you need to go to the bathroom at that time. And then mixed incontinence is exactly what it sounds like. It's a mixture of stress and urge incontinence, which is also very common since many of these types of incontinence are common after these procedures.
So what is pelvic health therapy? So what is a pelvic health therapist? A pelvic health therapist is a specialty trained occupational or physical therapist in the pelvic health field. We're specially trained to identify or treat the underlying causes of symptoms and pain. While medication can temporarily alleviate symptoms of pelvic conditions such as bladder control or chronic pain, pelvic health therapy focuses on identifying the root cause of the problem. We see that a lot. We see patients coming in, their goal is to get off medication if possible. How can we manage pain without being on pain meds? How do I control my bladder without being on bladder medications? And so these are the type of goals that we work with to achieve with our patients. What exactly is pelvic floor therapy? It's non-surgical, conservative, first-line treatment for many pelvic floor disorders and conditions. It is exercise. It's not only Kegel focused. We're very holistic and we cover multiple areas of the body. A lot of it is patient education. We love to educate. Knowledge is power. A lot of times just education solves a lot of patients' issues. Bladder education, defecation mechanics, which is how to have a bowel movement, different things like that. Fluid and food management. So how much should you drink? What should you drink? Believe it or not, things we eat or drink actually can cause a lot of our pelvic floor issues, bladder issues. We treat all genders, all ages. I mean, we see as young as a 20-year-old all the way up to, I think, an 85-year-old. What symptoms can we help with? Urinary incontinence. That's a big one. Overactive bladder. Urinary urgency and frequency. So having urgency, which means a strong urge to go too often, and then frequency going often. And complete bladder emptying and retention, and then pre and post operative care for prostate cancer, which is what we're mainly talking about today, and then any symptoms related to prostatitis, so pelvic and perineal pain, which we hope to eventually do one on prostatitis in the future as well.
Pre-surgical therapy, here's some things that you can expect at your first appointment. We typically start with one or more appointments, and that usually depends on how soon we can get you in before your surgery. Sometimes that can be the week before. Sometimes we get lucky and it can be a month or two before. And depending on how well you do with your exercise, your confidence level, we may have more appointments in the meantime to make sure you feel good before your surgery. But when you first come in, we'll sit down and have a discussion about your current medical history, any health issues you're having outside of prostate cancer that may play a role in your recovery. We'll talk about current sexual function, urinary function, bowel function, so that we have a good idea of what we're trying to get back to, or maybe even better after surgery. And then after that, we'll do an evaluation of your pelvic floor muscles. And an internal evaluation is similar to the digital rectal exam, except our goal is not focused toward the prostate. It's more focused on what are those muscles doing. So like Autumn said earlier, there's 3 layers of pelvic floor muscles, and we need to make sure that all of those layers are engaging when you're doing your exercises, but also throughout your daily activities that you do leakage, and that they're properly coordinating to do their job when they need to do their job. But don't let that discourage you if you're not comfortable with doing an internal exam. We can definitely do an external exam as well, or use biofeedback to help you make sure that you're doing your exercises right if that's something you're not comfortable with. But that is one of the best ways for us to tell if you're doing your exercises right, and to make sure that we're prescribing you the right home exercise program. So after the discussion and evaluation, we'll tailor a home exercise program to you based on what we find that day. And then we'll give you more patient education on your precautions, which is different for every patient because it will usually depend on your surgeon. And they usually have a list of precautions based on what they want you to do before and after. We'll talk about fluid intake, bladder irritants, what's safe for you to do with the catheter after the surgery. We can talk about being clean or cleanliness with the catheter, using pads and pull-ups and recommendations for that, among many other things that we can talk about that day. So our basic goal is to make sure that you feel confident before your surgery, you know what to expect, and that you know that people are in your corner to help you out if something's not going the way that you want it to after surgery.
I think people do find a peace of mind having the pre-op therapy, because we also give you what she kind of mentioned, kind of a post-op plan. Going to touch on the next 4 to 6 weeks before I see them or I see a doctor. What can I be doing to help this along? Versus other patients that have opted out of pre-op therapy. They were wishing they did it because of the leakage they had that 4 to 6 weeks. They didn't know how to help it and what to do with it. So it gives you a jump start, and it clears up a lot of your issues in the meantime.
When you come in for post-op therapy, it's very similar to your first appointment, except we already have a good idea of what we're trying to get back to. So we'll see you back about 4 to 6 weeks post-op, and we'll start with discussing what symptoms are you having? Are you having stress incontinence? Are you only leaking when you cough or sneeze or stand up out of a chair? Or maybe you only have leakage if you've been up and moving for a long time. So we'll go through basically the last 4 to 6 weeks. How have you improved? What are you still having trouble with? We'll also discuss bowel function, sexual function, any pain that you might be having after the surgery. And then we'll progress your exercises, go through different techniques, and almost like bladder retraining to get you back on track, going the same normal times a day instead of going too much to prevent leakage, but also healthily getting you sleeping better if you're waking up a lot through the night. So even though we're talking about post-op and, doing that 4 to 6 weeks post-op, don't feel discouraged if you've been 1 year post-op at this point, 5 years post-op, or you didn't even have surgery, you've had a different treatment, but you're experiencing some of these symptoms. Still come in for therapy, because even if it's been years since your surgery, we've treated many people who we've been able to help down the road. They just didn't know they were doing their exercises wrong, or they didn't even know that they had an option to try to make this better. So this is not only for someone who's newly post-op. You can always come in after your treatment or down the road to improve symptoms as well.
Definitely seen men 15 years post-op, 5 years post-op, and we've gotten really good results. So don't be discouraged. And yeah, like you said, you don't have to have had a prostatectomy in order to see us as well. All right, here is our contact information. Kristen's at the top and I'm at the bottom. Feel free to call that. That is our direct line. It calls us, our actual phone. And you can also email us. We're usually pretty good at getting back to patients within a day.
And the last thing I wanted to talk about today was looking for support. Tennessee Urology has a prostate cancer support group. Typically, we meet the last Thursday of every month, but due to COVID-19 right now, we're still meeting the last Thursday of the month, but it's through a Zoom meeting. There are still a lot of people on the meetings and we're able to do our group meetings as usual. The big thing about this support group is not everyone has a lot of family support or has the coping mechanisms or tools that they need to get through some of the mental, emotional, and physical hurdles that can be involved when it comes to prostate cancer. In my experience, prostate cancer is a very underserved type of cancer, and I feel like a lot of patients we've treated, they're just so tough on the outside, but really inside they might be struggling emotionally with what they've been diagnosed with. So family members and friends are welcome to come and join in and to give support or receive support, whatever that means or needs for you. And then the last thing about support group is Autumn and I can talk to you about pelvic floor therapy all day, but we can never understand what it feels like to go through these treatments or have this surgery. And so talking to other men who've been there, done that, can really help you make up your mind if you're trying to decide what type of treatment that you want, or if you're struggling after your treatment with what to do next, or what do I have to look forward to, and is this ever going to get better? So I think the support group is an awesome way to reach out to your community, but also get help yourself. And you can reach out to Autumn and I through our email or calling us if you want email reminders or updates on that. Or if you're just looking for other support nationwide, Google prostate cancer support groups and you'll find many, many, many support groups on a nationwide basis or community basis, depending on where you live. And that is all.
Yeah, thank you guys.